We're so glad you could join us today. My name is Aline Sigler with Provider Outreach and Education at WPS Government Health Administrators. Also on the line with me today is Ellen Barra, and you'll be hearing from her shortly. The purpose of this webinar is to focus on correct billing by physicians and critical access hospitals. You'll hear us refer to them as CAHs, if that's not a term that you're familiar with. CAH or CAH is how we refer to critical access hospitals a lot of times in the Medicare world. This next slide is to let you know that the information that we're providing is accurate and complete to the best of our knowledge. Medicare rules do change and change often, and the federal regulations are obviously going to take priority over anything that's in our slideshow or that we say verbally to you today. So you'll want to check back with those regulations to get the most up-to-date information. Medicare is also full of acronyms. So we pulled out some of the ones that we're specifically using in this presentation so that you can refer back to this slide if you need to. Okay? So what prompted this topic, or what do we hope to accomplish in our time together today? Well, we're going to define method 2 reimbursement. Critical access hospitals are unique from other hospitals in a lot of different ways, and this is one of those, and so we'll be sure to talk about that. You'll understand when separate payment for professional services is appropriate. We'll summarize a recent Office of Inspector General audit and report. You'll be able to identify improper payments and know how to submit refunds. If you haven't already, based on this OIG audit and report, you'll develop process improvements to prevent errors. As with a lot of our educational events, we'll point you to resources where you can find out more about this topic. So let's take a look at how critical access hospitals are different in the way that they're paid for outpatient services. There are 2 payment types, and you see them listed here. The standard method, or method 1, and the optional method, or method 2. And we'll talk more about each one of these in the next few slides. Medicare pays according to the standard method unless the critical access hospital elects the optional method. CAHs no longer have to submit an annual payment election under method 2. In years past, that was required for every fiscal year that the critical access hospital wanted to enroll in that optional payment method. That's no longer the case. Once a hospital elects method 2, that election remains in place until we're notified by the critical access hospital that they want to revert back to that standard method. You can read more about this in the Medicare Claims Processing Manual, which is Medicare Publication 100-4, Chapter 4, Section 250, starting in Section 250, and that's titled Special Rules for Critical Access Hospital Outpatient Billing. You can link to it from this slide when you download the PowerPoint if you're not familiar with how to get there. So let's define these 2. First up, under the standard payment method, critical access hospitals, or CAHs, like I said, are paid a facility fee for furnishing their outpatient services. And this is 101% of reasonable costs minus any Part B deductible and coinsurance amounts. These are sent to Medicare on a UBO-4 or the 837I electronic equivalent. Most of our providers, we recognize, do bill electronically. So we want to mention the 837I because if you're new to Medicare, you may not have ever even heard of a UB04 claim form or know what that is. And they use the 85X type of bill. Under Method 1, the critical access hospital is not paid for any costs of physicians or other professional services. So in this case, the physician or the non-physician practitioner sends a separate claim to Medicare on a CMS 1500 claim form or its electronic equivalent, which in this case is the 837P, P for professional. And these are paid under the Medicare physician fee schedule. Now let's compare this method, the standard method, to Method 2. As we said, a critical access hospital may elect the optional payment method, sometimes referred to Method 2, under which it's paid for professional services in addition to its outpatient facility payment. So as you see here, the facility billing requirements and payment are the same, 101% of reasonable cost minus any Part B deductible and coinsurance, and sent on the UB04 or the 837I. But in this case, payment for professional services is also included on that 85X type of bill. And payment for those professional fees is 115% of what would otherwise be paid under the fee schedule. However, this last sub-bullet here is very important. Only include professional outpatient services when the physician or the practitioners reassign their billing rights to the critical access hospitals. So on the other side of that, physicians and practitioners cannot bill for professional services once they've reassigned their billing rights to the critical access hospital. So let's explore that just a bit further. First, even if a critical access hospital elects the optional or Method 2 payment method, practitioners furnishing professional services to outpatients of that critical access hospital have the choice of whether to reassign their billing rights to the critical access hospital or file their own claims for professional services through their Medicare Administrative Contractor, or MAC. Practitioners reassigning their billing rights to a critical access hospital have to complete a form, which the critical access hospital will forward to WPS-GHA. We are your Part A and B MAC. And then as your MAC, we'll have the practitioners sign an attestation that clearly states that they will not bill Part B for any services furnished in the critical access hospital outpatient department once the reassignment has been given to that critical access hospital. And that attestation will remain at the critical access hospital. Now, at the time that this presentation was created, and in most of the documents that we'll be referencing today, you'll see that it says to complete the 855R to reassign Medicare benefits, Medicare billing benefits. Remember how I said just a few minutes ago that Medicare changes often? This is one of those times. CMS released a new 855I provider enrollment application on September 1st, so just a couple weeks ago. This new 855I consolidates the previous 855I and 855R application. The second handout that was in your reminder email that went out just a couple hours ago has more information about this updated form, when to use it, how to fill it out, that sort of thing. We also did a previous webinar on this topic, and you can watch a recording of that August 15th webinar. and you can find it by going to the Encore presentations page on our website or directly to the Encore playlist on our YouTube channel. So we want to make sure that you're aware of that, how you can read more about it, what the very specific timelines are for using that new form to make sure that you're in compliance. So moving on here and going back to what actually prompted this topic, this webinar today. While performing survey work on calendar year 2019 Medicare Part B claims, the Office of Inspector General, or OIG, found that critical access hospitals were paid for professional services provided by healthcare practitioners that received payment for the same services provided at the cost. So we had some instances where they suspected double billing, and so they wanted to take a closer look at that, and they decided to do a formal audit on these services. As a general rule, Medicare should not pay both a critical access hospital and a healthcare practitioner for professional services for the same dates of service. If you're not familiar with what the OIG's role is with Medicare, they are at the forefront of the nation's efforts to fight waste, fraud, and abuse. And they also work very hard to improve the efficiency of Medicare, Medicaid, and other Department of Health and Human Services programs. So once they took a closer look at some of these 2019 Part B claims that they were working on, they decided, like I said, to do a formal audit of these services. And their objective for this audit was to find out if those professional services paid to CAHs under Medicare Part B and the payments made to healthcare practitioners for the same services complied with federal requirements. So with every audit, there is a scope, and they have certain criteria that they are looking for when they're looking at claims. So the details of that audit are shown here. The audit period was March 1st, 2018 through February 28th of 2021. And the audit covered 40,026 claims. As you see here, the breakdown, half of those were submitted by critical access hospitals and the other half were submitted by healthcare practitioners for the same professional services provided to the same beneficiary on the same date of service. For those 40,026 claims, Medicare paid critical access hospitals right around $1 million and paid healthcare practitioners $872,858 for that particular sample of claims that they looked at. After looking at them, what they found was listed here. And this slide contains a link to the report that was filed for this audit in case you want to look at it more closely, see exactly what they found in their own words. After looking at the regulations for reassigning professional billing rights to CAHs, not all of the services that were audited followed Medicare guidelines. We established that the critical access hospitals and the healthcare practitioners each submitted an equal number of claims for the sample. That's what we looked at on the previous slide. However, for each date of service, only one of the claims was correct. And as a result, MACs, not just WPS, but nationwide, MACs paid providers $907,438 more than they should have. And because of this, beneficiaries were held responsible for $281,321 that they probably would not have had to pay for had the claims been billed correctly. So that was a startling fact that was found during this audit, and why we're talking about this today, to make sure that we all understand what the regulations are for billing for critical access hospitals and for the practitioners that provide services to those outpatients to make sure, number one, we are not overcharging the beneficiaries and making it a financial hardship for them, and also not overpaying providers and putting the Medicare Trust Fund at risk. If we break down those findings and we start with the hospital, for the critical access hospital, what was found that 12,156 claims from critical access hospitals who billed and were paid for professional fees when the billing rights had not been reassigned totaled $331,448. So that's the amount that was found to have been paid inappropriately. Now, on the flip side, the remaining 12,156 claims, 7,857 claims, were from professionals who had reassigned their billing rights to the CAH, but still billed the charges separately to Medicare and were reimbursed a total of $575,900. So that's the amount that was paid inappropriately to the practitioners or the professionals in those same audits, during that same audit time. Why did this happen? The OIG believes that, in part, these overpayments occurred because CMS did not have claim system edits that would prevent and detect duplicate professional charges for the same date of service, beneficiary, and procedure. However, even if there were not sufficient claim edits in place, it is still the responsibility of providers for correctly billing according to the Medicare regulations. We can't just bill everything and rely on the edits to catch the claims that are inappropriate. As providers, we need to make sure that what we're billing for is appropriate and correct. You know, errors can be fixed, but we want to prevent them. And that's why we're speaking about this today and giving you these reminders. So as that reminder, the critical access hospital can only bill professional services if the provider reassigns their billing rights to them. Once the reassignment has been given to that critical access hospital, practitioners have to sign an attestation, and it clearly states that they will not bill Medicare Part B for any services furnished in that hospital's outpatient department. We have listed several resources throughout the presentation so far as we've been going along here, and what we're talking about today, and a couple of them that weren't in the presentation yet, but we still want to make sure that you're aware of, are shown here. These go along with what we're talking about today. The first two are on the Medicare Learning Network, and the Medicare Learning Network is CMS's official source of information for Medicare fee-for-service providers. This first one, Information for Critical Access Hospitals, is what we call the CAH fact sheet. It is a good resource. It's a booklet that has all of the things we're talking about today, and then also links to more information where you can even read more. The second one, Rural Providers and Suppliers Billing. This is a unique booklet that offers billing information and resources not only for critical access hospitals, but also rural health clinics, federally qualified health centers, we call those FQHCs, home health agencies, skilled nursing facilities, any type of rural provider. And it's interesting because it's color-coded by provider type to help you find specific billing information for your provider type. The last resource that we're showing here is a link to the Critical Access Hospital Center on the CMS website. This will be updated with pertinent information or reminders or updates for critical access hospitals, but also serves as a jumping off point for other things related to critical access hospitals. So that's the end of the information that I want to present for you. I'm now going to turn it over to Ellen, and she's going to continue our conversation. So Ellen, please go ahead.
Okay, thanks, Aline. I appreciate that. Aline, we did have one kind of, I think, an interesting question that came in before I kind of get started here. And the question came from Karen and said, would this include the information that you've talked about? Would this include the professional component for a pathology interpretation?
That's a very good question, Karen. So for the professional services, this is going to be your evaluation and management services, so it very well could be. There's more billing details in that claims processing manual section that I referred to, and it talks about the very specific revenue codes that you'd be using. And so if it did fall into the category for those professional services, then it very well could if that provider had reassigned their benefits to that critical access hospital. I hope that helps.
Okay, thank you, Aline. And we do have one additional question, and this is from Lori. And Lori asks, or states, it is my understanding that method 2 only applies to outpatient services provided in the CAH, and that inpatient services in the CAH, the physician or practitioner would still bill to Part B on a 1500. Is that correct?
Yes, that is correct.
Okay, thank you, Aline.
Certainly.
All right, so the slide that you have up on your screen right now is titled Working Together. And as Aline has talked about, in order for CAHs and physicians to really kind of do this correctly, they have to be working together. It is a decision by the physician or the practitioner to reassign their benefits to the CAH. So when that physician or practitioner has made that choice, as Aline talked about on that now 855I form, they're signing that and they're attesting to the fact that they understand they have reassigned those benefits. So then they need to be, that physician or practitioner needs to make sure that their office is aware of that, so that for those outpatient services provided to those CAH patients, the provider is not going to be billing for that. You can see we have listed here 855R. However, as Aline talked about, CMS does change often, and this is one of those things that has changed. So the physician has to be aware they're making a deliberate choice in order to reassign those benefits. When they're doing that, then the CAH also has to be aware of who those physicians are that have reassigned their benefits. Providers can do services in an outpatient department of the CAH without having to reassign their benefits. They would simply bill those services directly to us. But both of those organizations, both the physician or non-physician practitioner and the CAH itself, need to be aware that Dr. Smith has reassigned their benefits, but Dr. Jones has not. And so you're going to bill for, the CAH is going to bill for the services provided by Dr. Smith, and Dr. Smith is not going to bill for those separate, whereas Dr. Jones, because he has not reassigned benefits, Dr. Jones will bill for that separate, and the CAH will not bill for that. We go ahead to the next slide, Aline.
I apologize. I'm trying. I'm frozen here for a second.
Okay, if you stay frozen.
There we go.
There we go. All right. So providers can have separate practices. There can be information, or there can be patients that they're treating that are part of the CAH, and they've reassigned those benefits to the CAH. So the CAH is going to bill for those. not the physician or practitioner. The physician or practitioner could have their own separate practice. And so then for services that are provided within their offices where the patients are not patients of the CAH, then they can separately bill for those. Again, with this method 2 billing, both practitioners really have to pay attention to that reassignment of the benefits and then identify, is this a CAH patient? Is this not a CAH patient? As Aline talked about earlier, the CAHs can still bill for their facility charges when that practitioner has not reassigned benefits, but then that's not going to include those professional charges. It's just the facility charge. And then if the practitioner has not reassigned benefits, then they can bill separately. Again, if they have reassigned benefits, then they don't want to bill separately for that. The next slide that we have talks about a self-audit. Aline talked about the fact that the Office of the Inspector General has done an audit on this. And so they have identified claims through that audit where the billing is incorrect, where either the CAH billed for something that they shouldn't have billed for, or the physician or practitioner billed for something that they should not have billed for. However, they did not look at all claims. They looked at a sample of claims within those dates that Aline identified. And they're not looking at current claims. So what we're asking you to do is really to examine your processes. Has your physician or practitioner reassigned benefits to the CAH? Is this particular patient registered with the CAH? If that patient is registered with the CAH, then your physician office is not going to bill for that. The CAH will bill for both the facility charges and the professional fees. If there isn't a reassignment, then both of those entities would bill separately for that. Some of the things that the CAH would be looking for. This service was provided again today by Dr. Smith. Can we identify and do we know whether or not Dr. Smith has reassigned those benefits to the CAH? If they have, then the CAH is going to bill for both the facility and those professional fees. If Dr. Smith has not reassigned benefits, then the CAH is only going to bill for those facility fees, and then Dr. Smith will bill for his fees. So we're asking you to do a self-audit, to really take a look at the services that you're submitting to Medicare. Are those services appropriate to be submitted to Medicare? And then to make changes to your internal workflows to prevent that future billing. And again, that's going to be on both the CAH and on the professional side. As we talked about earlier, Aline, we can go ahead and go to the next slide. As Aline talked about earlier, not only were there incorrect payments by Medicare, but there were also incorrect payments by the beneficiaries. The beneficiaries were being held responsible for their coinsurance or deductible for services that they really had no responsibility for. So when you're going back and doing these self-audits, and we really do encourage you to do these, you should go back at least 4 years in looking at the claims that you have submitted, the providers that are involved, looking for those reassignments. And this is effective for both the CAHs and for the professionals themselves. You want to determine what was really the correct billing. Should the physician or practitioner's office have billed Medicare for this, or should the CAH office or facility should have billed this into Medicare? So if the billing was incorrect, then we have to determine, well, who should make the refund? Well, that's all going to be based on, did that professional reassign benefits to the CAH? If that professional reassigned benefits and the professional was paid for that service, then that professional is going to have to refund. If the CAH billed for something where benefits were not reassigned, then the CAH should be making that refund back to Medicare. And when you're doing that refund, you're going to be refunding not only back to Medicare, but also back to the patient or the patient's supplemental insurance or Medicaid for any coinsurance and deductibles that were paid by that patient incorrectly. We can take the next slide now. So on this slide here, we have overpayment return instructions. And we wanted just to kind of bring your attention to this. We have an article, and it's linked out here for you, on unsolicited voluntary refunds. So this is where you're identifying the fact that there should be a refund back to Medicare, as opposed to Medicare itself identifying that there is a refund. You can submit on paper. There's forms out there that you can use. You want to identify the specific claims, and then you want to make the check to WPS or to Medicare. However, the easiest way that you're going to be able to do that is electronically. And you can submit the voluntary refund for each of the specific claims that are involved. In the information on the portal, you're going to do the Medicare refunds and then do the e-fund entry in the transactional portal itself. On our portal, at the bottom of the page, in that blue box that's contained at the bottom, there is a manual, a portal manual that goes along with all of the information in that transactional portal. So you can find specific instructions in there in order to do this refund. We will, once you identify the refund, we will then notify you back that yes, you need to submit the refund back. So again, you can do it either way. If you are going back and you're looking back at least 4 years, which is what we have instructed you to do, you need to go back at least 4 years. You can submit on paper and you can use that form to identify all of the claims. Once you do that, then you'll submit that along with the check that comes back into Medicare. Then electronically, you'll identify each of the specific claims and do that transaction separately. We have a YouTube playlist on overpayments that has multiple videos, encore presentations, etc., dealing with overpayments that really provides a lot of great information that you can take a look at. Next slide, please. The next slide talks about the False Claims Act. As Aline talked about earlier, the Office of the Inspector General, that's one of the things that they're responsible for, is really making sure that Medicare is paying claims appropriately. They're looking at those situations where we're not. They're making recommendations back to CMS on what possibly the Medicare processing system can do in order to prevent these in the future. Aline mentioned a suggestion on editing and auditing. The link that we have, that first one, Laws Against Healthcare Fraud, there's a lot of great information in there. It talks about the False Claims Act, which is submitting a claim that you know is false. There's anti-kickback statutes that are listed in there, along with some others. Part of what's under the False Claim Act is knowingly and willingly. So this is actual knowledge. So providers have been given this information. Aline provided you with multiple references that go along with that. It is a deliberate ignorance or reckless disregard of the instructions. So let's go back to what Aline talked about earlier. When you're signing that 855R, if you signed that before or now, the 855I, you're attesting to the fact that you understand that as a physician or practitioner, you should not be billing those professional services to Medicare. So if Medicare comes back, or you're part of the OIG audit, or another audit is done, you really can't say, well, I didn't know. And so, therefore I should not kind of get in trouble for this. Well, Medicare says you did know, because it's on that attestation. The instructions are out there for the CAH method 2s. So again, it goes back to working together. When that provider is doing services for that patient in the CAH, outpatient department of the CAH, then the CAH number one needs to understand and needs to develop for, is there a reassignment? If so, they're not going to bill that professional component. On the physician side, if they have signed that attestation and have reassigned those benefits, then that physician or practitioner office should not be billing to Medicare. And so, just like Aline talked about, there was a lot of dollars involved in that OIG audit, not only that Medicare paid, but also that the patients were responsible for. Under the False Claims Act, there's another provision that goes into failure to return an overpayment. So if you identify an overpayment within your offices, you need to be refunding that back to us within 60 days of the overpayment identification. So on the previous slide, we suggested to you that you perform a self-audit. Now, especially given the fact that you do need to go back 4 years, at least 4 years, in order to do this self-audit, you may want to consider doing those overpayments back to us on an ongoing basis, rather than identifying all of them first and then refunding them all back at the same time. You have 60 days from the date that you identified that there is an overpayment. Next slide then, Aline. So what you have up on your slide right now, and we're going to leave this up for just a second, is a survey that we ask you to complete based on the presentation that we provided for you here today. You can use your smart device in order to scan that QR code, and you can do that now. If you don't choose to do that, the materials that we sent to you, you can click on that word survey and it will take you to the survey information. And then when you leave the webinar today, you will get another page that comes up that looks similar to that box in the middle of our slide. And it says external site. It has that yellow triangle on the bottom. This is not spam or anything else. What it's telling you, what WebEx is telling you, is that we have placed a post-webinar link in the webinar itself to take you to the survey. So if you hit that blue continue button, then that will actually take you to the survey itself. So what we're going to do now, before we go on to anything else, I'm going to leave the survey information up here for you for a minute, is we're going to go back in and look at the questions that we have received. So let me scroll back up on our questions here real quick. All right, so the first question that we have, and this is from Mary, and it says, how does chronic care management work with CAH method 2 billing? And chronic care management is going to work the same way. As Aline talked about earlier, what we're talking about here are the professional services by those physicians and non-physician practitioners. So if that non-physician practitioner is billing for a CAH outpatient patient and they're billing chronic care management services, then and they have reassigned benefits, then the CAH is going to bill for that. We have information available on our YouTube channel, on our survey, on our Encore page, on our website that goes into chronic care management, and there's all kinds of different resources. I think we have about 25 or 26 different videos. One of those videos is specific to hospital outpatient department billing. A hospital outpatient department can submit for chronic care management services. In addition to the professional being able to submit for a method 2 CAH, all of that's going to come in together. So the CAH would bill for that, and they would bill the appropriate procedure codes based on what service they're actually providing to that individual patient. Let me scroll down. Let's see, we answered that one. Okay, the next question that we have is from Becky, and it says, what about billing, or what about when billing for an emergency department provider? And Aline, correct me if I'm wrong, but that would work the same way. It's an outpatient service. If that CAH has elected method 2, if that ED provider has reassigned benefits to that CAH, then the CAH is going to bill for those professional services, not the ED physician. If the ED physician has not reassigned benefits, then the CAH will bill for the facility charges, and then the ED physician will bill their professional charges separately. It all comes back to, is it a professional service, and has that physician reassigned benefits? The next question is from Lori, and it says, we have a hospital-based clinic that is not inside the walls of the CAH, but is on the CAH campus. Would method 2 apply to this clinic if benefits were reassigned? Aline, I think I want kind of your feedback on that one. If it's a hospital-based clinic of the CAH, then would all of the method 2 rules still apply to that?
Thanks, Ellen. Thanks, Lori. Great question. It depends on how that clinic bills and gets paid. Are they paid as a clinic under the all-inclusive rate and following that route, or are they considered hospital billing on an 8.5x under either the standard method or method 2? So it depends on how that facility, as the hospital-based clinic, is registered with our provider enrollment area.
Okay, thank you, Aline. And we also have a question from a different Lori, and it's, is this the same billing process for an off-campus hospital outpatient department of the CAH? And as Aline said, it would be based on how you have enrolled that and enrolled that particular off-campus hospital outpatient department, and then whether or not that provider has reassigned those benefits to you. The next question that we have is for Julie. And Julie's question is, how does this apply to inpatient admission for a swing bed placement? A swing bed placement is going to be basically a skilled nursing facility visit, and that would be considered an inpatient service. And so method 2 applies to outpatient departments as opposed to the inpatient. And so in this situation, the CAH is going to bill for the swing bed, and then the physician would bill separately for that inpatient admission. Aline, do you have anything you want to add to that?
No, you are correct.
Okay. All right, I'm not seeing any additional questions right at this time. The chat is obviously open, so you can certainly respond. Julie asked a follow-up question. So the place of service then would be 31, and that is correct for the professional service. They're being admitted to that swing bed, and if they're classifying that patient as a skilled nursing facility patient, then the professional services would come to us under a place of service code 31. Okay, so let's go ahead and go on to the next slide then. So what we have in front of you now is your proof of attendance. This is what you can use in order to submit to your accrediting organizations so that you can collect those continuing education units. Now, the slide itself is not what you would use, but let's talk about this. So number one, we need you to complete the survey. The email that you're going to get following this presentation, excuse me, probably about an hour and a half or so, giving you time to do that survey, will contain what's over on the right-hand side of your screen. It's thank you for attending. However, don't stop reading there. If you go down further in that email, you'll see that it states certificate, and then under that is certificate of achievement. The email is going to have your name on it, and then that certificate of achievement provides you with the title, it provides you with the date, and then it provides you with the contact hours. This email you can submit to your accrediting organizations in order to receive those continuing education units. I myself am part of American Academy of Professional Coders, AAPC. I can simply upload the email directly into that. I'll just identify that there's no index number and then upload the email itself, and then I can get the 1 hour's worth of credit. The email is going to contain all that information we talked about. Over on the left-hand side of your screen, this email is going to come from Messenger at webex.com. Check if you don't get it within the next 2 hours, check your junk or your spam folders, and then you want to add that email address to your safe sender or safe receiver list so that it comes into your inbox as opposed to your junk or spam folders. Aline, we can go on to the next slide. So I'm looking in the chat and I'm not seeing any additional questions at this time. However, we know that sometimes you go back to your desk or go back into your office and you go, oh, wait a minute, I should have asked this. Well, you have an opportunity to do that. You can send an email, and that's our education email box listed there for you on the slide, wps.gha.education@wpsic.com. In the topic, you want to include the title of this presentation, correct billing for physicians and critical access hospitals, and you want to include the date. You need to submit these to us, any follow-up questions, by 9/23 at 12 noon. What we will do with these questions then is evaluate those. We will look for information that maybe we need to add to our website. We will look at information that we need to respond back to everyone who's on the call this morning, and then also who's going to be on the call this afternoon, or whether it's something we need to respond directly back to that requester. We can't take any PHI or PII in those emails. Any claim-specific questions would need to go to our customer service area. The questions that we can take here are similar to the ones that we have responded to so far, really dealing with the rules and regulations that go along with method 2 billing, what the physicians are responsible for, what the CAHs are responsible for. And I think that's our last slide. I don't see anything else in the chat. We'll hang here for just a second to see if we do have any additional questions. If we do not, on behalf of Aline and myself and the rest of our PO staff members, We want to thank you very much for taking time out of your day to attend this presentation today. We encourage you to really look at performing that self-audit. It would be highly unlikely that even if you weren't part of the specific OIG audit, that you may not have situations where you need to refund back to Medicare. So that's all that Alina and I have for you today. Again, I'm not seeing any questions in the chat. Julie, thank you for your feedback. We appreciate that. You can now disconnect.
Thank you, everyone. Have a good rest of your day.